In terms of the available testing for ALK rearranged non-small cell lung cancer, you have a couple of options. One is, broad-based genomic profiling with next-generation sequencing, which is typically what I send out because it enables us to at least initially get an identification of potentially, looking at trying to find different mutations that you can match to targeted therapies rather than focusing on one. ALK FISH and ALK IHC are also methods that are used, and ALK IHC and FISH may have a quicker turnaround time. So sometimes if I really suspect ALK, for example, they can be associated with pericardial effusions, pleural effusions, and I've had patients with that where you send off an ALK IHC and potentially can get that quicker and then intervene on that quickly. We have had cases like that at our institution. That could be done as either a standalone test or a screening test and then do a confirmatory test, or it's approved as a standalone as well. So those are the different methods used. In terms of using circulating tumor DNA, I often send that out if I need a quick result, because that may come back faster than looking at a tissue biopsy where if you need a repeat tissue biopsy, or if you or if you think there may be insufficient tissue, sometimes there's not enough circulating tumor DNA being shed in the blood where a negative test doesn't disprove it. It could be a false negative where tissue is important. But those are kind of the techniques that I use. There's some folks that think more about RNA-based methodologies that may be more accurate in detecting ALK fusions and fusions in general. But I think for me, the general standard is broad-based genomic profiling with next generation sequencing.
Currently at my institutions, I have options. I can choose my own next generation sequencing, or I can send it out to a reference company. I test all my patients with non-squamous, non-small cell lung cancer, metastatic, for ALK rearrangements and other rearrangements we've discussed. I also test my patients with squamous cell carcinoma if they have a certain phenotypic characteristics. For example, if I see a patient with squamous cell carcinoma who was a non-smoker, or if I see a patient with squamous cell carcinoma who had a small biopsy on FNA, which made the basis for the diagnosis. For those patients, it is certainly possible that you are dealing with what's called a mixed histology or adenosquamous lung cancer, and those patients can harbor ALK rearrangements. Also, if you remember, the first patient with ALK rearrangement, which was described by Dr. Soda, was actually a patient with squamous cell carcinoma. So for a certain subset of patients with squamous cell carcinoma, I do test for ALK.
BFEST, is a very interesting study. We actually participate in it at our institution. It basically utilizes ctDNA testing up front to allow quick introduction of targeted agents or immunotherapeutic drugs dependent on findings. And it certainly is very easy to force the integration of that into our practices, since we use ctDNA very appropriately already. So in a way, it will be a very, very smooth transition towards practice. Basically, what the study has shown, that if you use ctDNA and detect ALK alterations in ctDNA, you can offer alectinib with a great chance of success. And this really confirms the paradigm that we've seen from other studies, especially from the EGFR field, for example, FLORA, where we could see that ctDNA detected EGFR alterations yield excellent outcomes in terms of EGFR targeting, similar to obviously with tissue-based testing. So this will be sort of a slam dunk in terms of incorporating into our practices and facilitating the care of our patients.